chairperson and colleagues. I would like to present you our study entitled Choroidal Vascularity Index as a biomarker of systemic inflammation in childhood polyarteritis nodosa and adenosine deaminase 2 deficiency. Polyarteritis nodosa is a systemic necrotizing vasculitis affecting small or medium-sized arteries. PAN is rare, pediatric PAN is even rarer. Whole exome sequencing has enabled the identification of deficiency of ADA2, which is the first described monogenic vasculitis syndrome and to date misdiagnosed as PAN. PAN and ADA2 show a wide range of clinical manifestations, including systemic symptoms such as fever, myalgia, and weight loss, as well as cutaneous, gastrointestinal, renal, and neurological involvement. Ophthalmological manifestations, which occur in 5 to 40% of patients, are relatively uncommon compared with other organ systems involvement. The major ocular findings are retinal vasculitis, cotton wool spots, and choroidopathy. The choroid, as the most vascular structure of the eye, consists of a capillary network and larger choroidal vessels. Enhanced deep imaging is a commercially available non-invasive modification of standard optical coherence tomography. It has enabled us to assess choroids, which could not have been evaluated in detail before by methods such as fluorescent angiography or ultrasonography. Choroidal thickness alterations have been noted in some systemic and inflammatory diseases, and studies conducted on adult rheumatoid arthritis and lupus patients have shown a 25% decrease in choroidal thickness due to chronic choroidal vascular inflammation. In this study, we aim to investigate possible subclinical ocular involvements in PAN and ADA2, which may precede sight-threatening complications. We assessed EDI-OCT of choroid for inflammatory signs in children with PAN and ADA2. In this study, we had 11 children with PAN, 4 children with ADA2, and 15 age-matched healthy children. PAN was diagnosed according to the Ankara 2008 classification criteria, and ADA2 was diagnosed by defining the mutations of ADA2 gene by Sanger sequencing. In this study, all ADA2 patients were homozygous for G47R mutation. And the ophthalmological assessment performed by our Department of Eye, including complete ocular examination and EDI-OCT scan as well. In Table 1, you can see the clinical characteristics of PAN and ADA2 patients at the time of diagnosis. And in Table 2, you can see the main characteristics of patients at the time of diagnosis and at the time of OCT visit. The median age at the time of diagnosis of patients with PAN and ADA2 were 6 and 4 respectively, and the median age at the time of OCT visit of patients with PAN and ADA2 were 8 and 6 respectively. At the time of diagnosis, the most common symptoms were myalgia and arthralgia, followed by fever and fatigue, abdominal pain, rash, hypertension, and testicular pain. At the time of OCT visit, all PAN patients were in remission, and only 1 out of 4 ADA2 patients was confirmed as having active disease due to the presence of vasculitic rash and arthralgia and elevated acute phase reactants. And here in Table 3, you can see the comparison of OCT findings between PAN and ADA2 patients and control group. We found that the choroid was significantly thicker in children with PAN and ADA2 compared to control group. And in post-hoc analysis, we couldn't find any significantly difference between PAN and ADA2 patients. And correlation analysis didn't show a significant association between OCT findings and PVAS and laboratory results. As a limitation, we had a relatively small sample size of patients with PAN and DADA2, and this study was cross-sectional. And in conclusion, this study is the first case series describing choroidal involvement in children with PAN and DADA2, and the choroid was observed to be thicker in PAN and DADA2 group with an increase in the luminal, stromal, and total subfoveal choroidal area. Thank you for listening.